Sandeep has shuttled many flights and come from flood-ridden areas to be with us today morning. So should give him a warm welcome. Yeah. So please use the scanners for questions, everybody. We are just running about 10 minutes late because of the tea break. We are sticking to our time. I'm going to request, and everybody is keeping their time so far. Sandeep, over to you.
Thank you so much. Good afternoon. Heartfelt thanks to Srinivas for inviting me to Hyderabad for this conference. Yes, I reached pretty late, early morning today. I missed my flight and Delhi connection. So this talk was given to me yesterday morning only. I'm filling up the shoes of somebody else. So we'll be talking about role of drug-induced sleep endoscopy in improving the outcomes in OSA treatment. Now we must realize that why are we doing DISE first of all, and then comes the role of the drug-induced sleep endoscopy. So I'll try to be very brief and take you through few facts about drug-induced sleep endoscopy. So the gold standard treatment, what we have seen is what has been advocated all these years is CPAP, and it acts as a pneumatic splint. Now the problem is that if it was gold standard treatment, then we should not have been here discussing all these problems, and the compliance is pretty bad. And then the American association says that effectivity 4 hours is enough, which is not the case, and there have been studies which say that at minimum 6 hours of CPAP usage per night is required for our compliance, for the cardio comorbidities to decrease. And again, that famous controversial, of course, paper by Rottenberg, Kenny Bank about the poor compliance. Now, so we need to offer an alternative treatment option to the patient, and who have failed CPAP therapies, who are intolerant towards CPAP therapies, or those young patients who are not keen for CPAP therapies. And more OSA is being seen in young patients, and they are not at all ready for CPAPs to be used throughout their life. So, and what else we can offer is surgery. Now, we need to be taking care that the famous study by Sher et al., which said in 1996, which said that unselected group of patients who underwent UPPP, only 40% patients had that success. And recently, again, there was a systemic analysis which did not support that widespread of use of surgical treatment for unselected patients of obstructive sleep apnea. So that's why we need the assessment, and that's why we need the drug-induced sleep endoscopy, because it changes the evaluation. This evaluation changes the treatment plan in 50% of the patients. You know, this is according to the literature and data we have. We all have our own ways of doing DISE, concepts about DISE. You know, all have different views about DISE, but it definitely changes the treatment plans. So we need to have a surgical planning, and we need to select the correct procedure to be performed on the correct patient. That's very important. Apart from the static obstructions which are seen, which we can come to know about on nasal endoscopy or FLP also in our OPDs. So that is a deviated nasal septum or adenoids or polyps or nasal mass. We need to know about the dynamic obstruction. We need to know what happens exactly at the sleep, during sleep, at the level of the velum, at the level of the oropharynx, tongue, and the epiglottis. And that will help us to decide what kind of surgery we need to do. We do need to do a soft tissue surgery or a skeletal tissue surgery, or maybe, you know, if it's not an anatomical factor, it might be a non-anatomical factor, which Rahul has just very in detail elucidated. So moving on, we need, if we talk about drug-induced sleep endoscopy, we need to have an ideal anesthetic drug, which we still have not been able to find. So, and then we all have our own ways of doing DISE. We need to have the only thing, constant thing we need to find is that we need to have a BIS monitor, which will give us a level of the depth of the sedation. You want to use propofol, you want to use dexmed, you want to use in combination. It all depends upon what protocol you are following. And there are many different literature which mentions different. The vote classification has been accepted nowadays, and for referrals also, for discussing patients we need to do. So now we come to the very important part, that we are talking about that how it can improve the outcome. But first of all, we need to come to at the same level, that is DISE a standard protocol or a standard procedure to do. So the controversy is that it is not a natural sleep. But AHI and SpO2s are quite similar. There are enough studies and literature on that, and only the sleep macrostructure is altered, not the microstructure. The depth of sedation, if we use propofol, especially if we are not using a target controlled infusion system, then the patient can go deep very quickly. So this can be taken care by the BIS and the target control infusion system, and so there is agreement on that. There has been many studies which say that the inter-observer variability is acceptable, and so this has also been accepted to some extent now. And the non-uniformity of using different classification system, vote has been uniformly accepted, and there have been European papers on DISE and so on. There will be another, I think, observational system from our colleagues also. So the famous paper by Raj Dedia and Melissa, which again said the evaluation of sleep changes treatment choices by 50%. So that is why the DISE is important, and the paper by B. Kotecha and Andrew DeVito, which finally they say is that DISE continues to be the more and more popular as a selection tool considering upper airway surgery in patients with SRBD. Now we did our own RCT in which we tried to find a drug, the ideal drug, so-called ideal drug, dexmed versus propofol, in which we found that it is not any of these drugs are important over each other. You can use both the drugs, however comfortable you are. The only thing is you need to have a BIS or a target controlled infusion system when you're working with with propofol. We can't go into the details of this. And then another very important paper which says that the primary epiglottic collapse or the laryngeal OSA was seen in about 30% of the patients, which is more number. Usually we see 15 to 20% of the patients. And DISE is one investigation or a procedure which can give us an idea about primary epiglottic collapse. In this, CPAP is contraindicated, so patient can be explained and counseled to go for a surgical management right from the word go. So another recent paper, very recent paper, which says about that the emerging role of DISE in management. When we do a DISE, if we see a lateral collapse of the lateral pharyngeal wall, or if we see a hypopharyngeal collapse, we are all usually doing, we were talking about unselected patients. If we do an unselected UPPP or any palatal procedure, and the patient has a lateral collapse or a hypopharyngeal collapse, we are not going to get good results. So DISE can also help us to think or seeing if a skeletal surgery is the first approach to the patient. Apart from craniofacial deformities or retrognathia, of course, in those patients we need a mandibular advancement or MMA. But even for the soft tissues also, we might have to go an external framework surgery like a thyroid heart suspension or some other skeletal procedure, a mandibular advancement. So here, this DISE can help us improving outcomes by looking at that subset of patients which might need a skeletal framework or an external framework surgery rather than the soft tissue approaches. Another article which says that it improves the DISE improves the surgical treatment is that they did a retrospective analysis of patients who underwent surgery with DISE and without DISE. And what was the finding? That they say that there was a decreased rate of multi-level surgery and increased surgical success on identification and seeing the individual patterns of OSA architecture, so that on customizing the surgical plan according to the DISE findings, they could improve the surgical results and decrease the multi-level surgeries also. Another study which tells us about patients undergoing DISE and between DISE and non-DISE patients, and they say that the airway dimensions at the level of velum and oropharynx with the jaw thrust may benefit most of when we are doing a oral application appliance therapy. So the DISE not only help us to get better surgical result, it can also help us in appliance therapies also. It can help us in CPAP therapies also. They are all part of treatment for OSA. Surgery is not the only treatment, so it can help in that. There have been plethora of papers in the last couple of years about DISE CPAP. We also published our RCT on that, and in which this is the same, something like what Srinivas was talking during the surgery about POP and FOP, the Brazilian group which has come out with the concept of POP and FOP. So similarly, we've seen that when we do a DISE with CPAP, the auto titration which is done by the machine, the pressures attained are a bit more when you actually see during DISE to attain a complete opening of the airway. So that is why maybe the patient's airway was not opening when we do a in-lab titration. The patient was not comfortable. They were not getting optimal results, and so that's why they were not using the CPAP to that extent. So that is how, if we use a DISE CPAP, we can help to get that particular pressure which opens the airway maximally, and we can that's a titration done, and then we can put the machine at that pressure so that the patient gets better results.
Just keep a watch on your clock, sir.
Yeah. I have 15 minutes.
You got 3 more minutes.
3 more. I'll finish.
Because I know your summarization is good, so I want them to get.
So we talk about these. We will not go into the DISE videos. I just want to show you a primary epiglottic collapse. See, now these patients are, when you see a primary epiglottic collapse, we need to take these patients for surgery rather than CPAP therapy, because what will CPAP happen? What will CPAP? So when you use DISE, when we use CPAP with primary epiglottic collapse, in spite of the airway being open, epiglottic collapse ho gaya. So this is what will it call? It will close the epiglottis like a trap door, and this is what will happen. So what is the potential roles of DISE if we see? It can help us in putting oral appliances. It can help us to see the positional therapy. Of course, it will get some idea from the PSG, but we can actually see during DISE. It will help us to improve our surgical results between skeletal and soft tissue frameworks. It will help us to determine, and of course, we don't have hypoglossal nerve stimulation, but DISE is important in that if there is a circumferential collapse, those patients are not good candidates for implant. So DISE will help us in that way also. So whether it is CPAP, whether it is oral appliances, whether it is deciding between skeletal and soft tissue work, or whether it is a hypoglossal nerve implant, in all these cases, when we do a DISE, we are much better aware of the dynamic things going on, and we can plan our surgery much better. So summarizing the direct visualize the site and pattern of obstruction and the structures, we need to plan our surgical treatment. It has good reliability and inter-observer validity. Jaw thrust or the edge marks can also be seen during the DISE. The epiglottic collapse can be established. It can help in improving the CPAP effectivity, and it's a safe and effective tool which will help us to improve the outcomes of CPAP, oral appliance therapies and surgery. Thank you.
Thank you.